أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Ameen Ya Rabbal Alameen. Bismillahirrahmanirrahim. Assalatu wassalamu ala khatamin nabiyyin. Assalamu alaikum and a very warm welcome to all of you for this second session of South Asian Federation of Endocrine Societies and Pakistan Endocrine Societies Diabetes and Ramadan webinar. This is our second session. We had the first session on 20th of February. As all of you know, in the Surah Baqarah, verse number 183, Allah subhanahu wa ta'ala says, O believers, fasting is prescribed for you, as it was for those before you. So perhaps you will become God-fearing. The holy month of Ramadan falls on the 9th month of the lunar calendar. It is one of the 5 pillars of Islam. Ramadan involves fasting every day for 1 month between dawn and sunset. Fasting is an important component of Ramadan and allows Muslims to devote themselves to their faith. The month long, which can either be 29 days or 30 days, depending upon the lunar sighting, fast is obligatory for all healthy Muslims who have reached puberty and is a time for spiritual contemplation and seeking nearness to Allah subhanahu wa ta'ala. Followers must refrain from eating and drinking between pre-dawn and sunset and must abstain from using oral medications, sexual activity, and smoking. And it is believed that spiritual rewards for good deeds are multiplied many times during Ramadan. And there's an intense desire to participate in fasting, even among those who could seek exemption, such as the elderly, children, the infirm, and pregnant women. So I'll first introduce to you our panel of experts for today's session. I am Dr. Aisha Sheikh. I am Pakistan Endocrine Society's president, and I'll be moderating this session for today. I work as a consultant endocrinologist at Aachen University Hospital and am a recognized tutor at University of South Wales, UK. We have experts from SAFES countries. I'm glad to introduce to you Professor P.K. Jabbar, who is the current president of Endocrine Society of India. Dr. Jabbar is the professor and head of Department of Endocrinology, Government Medical College, Trivandrum, and he's the professor and head of Department of Endocrinology and director, Indian Institute of Diabetes from India. Welcome, Professor Jabbar. We have with us Professor Sanjay Kalra. Professor Kalra is the past president of Endocrine Society of India and past president of South Asian Federation of Endocrine Societies. He's the past president of Indian Professional Association for Transgender Health and chairperson for Educating Working Group International Society of Endocrinology. He is also an international member of Pakistan Endocrine Society and editorial advisor for Journal of Pakistan Medical Association. He's very well published. All of you must have read his work. He's a very enthusiastic author, and he has published a lot of research articles in national, international, and regional journals. Welcome, Dr. Sanjay Kalra.
Thank you.
Now I move on to Professor Hamid Ashraf from India. Professor Hamid Ashraf is endocrinologist and an associate professor and ex-director at Rajiv Gandhi Center for Diabetes and Endocrinology, JN Medical College, Aligarh Muslim University, Aligarh. He has more than 40 publications in international and national journals, and he's the editor for Sage and Frontier publications. He's a reviewer for BMJ Frontiers Endocrinology, Indian Journal of Endocrinology and Metabolism, and Diabetic Medicine. Welcome, Dr. Hamid Ashraf, to this session as an expert panelist. Now we'll move on to our next expert, who is Dr. Mariam Niaz. Dr. Mariam Niaz is from Maldives. Dr. Mariam did her MBBS from Pakistan, and she's master's in internal medicine and fellowship in endocrinology from Malaysia. She is a consultant subspecialist in endocrinology in Indira Gandhi Memorial Hospital, Maldives. She's the vice dean of National Healthcare Academy in the same institutions and council member. She has an extensive experience of teaching undergraduate and postgraduate students and is a national and international speaker on endocrine disorders. Welcome, Dr. Mariam Niaz. Now we'll move on to our next speaker, who is Dr. Muhammad Wali Nasiri. Dr. Wali Nasiri is from Afghanistan. Dr. Nasiri is the faculty at Kabul University of Medical Sciences. He has extensive experience in undergraduate and postgraduate teaching, Director of Education Development Center at Kabul University of Medical Sciences, and consultant endocrinologist at Al-Ibad Teaching Hospital. He is the chairperson of Research Committee and Institutional Review Board of the same institution, and is the current president of Afghanistan Endocrine Society and one of the founders of Afghanistan Endocrine Society. He is an author of textbook of endocrinology and diabetes for dentistry medicine, Kabul University, and has published research articles in national and international journals. Thank you very much, Dr. Wali Nasiri, for joining this session. Next, we'll move on to Dr. Faria Afsana. Dr. Faria Afsana is from Bangladesh. She is the Associate Professor, Department of Endocrinology, Burdam, Dhaka, Bangladesh. She is the President-elect of Bangladesh Endocrine Society and the President-elect of South Asian Federation of Endocrine Societies as well. She is the past General Secretary of ACE Bangladesh chapter. She has an extensive experience in undergraduate and postgraduate students, published research articles in national and international journals, and she's a speaker, a very eloquent speaker for national and international conferences on endocrine disorders. Welcome, Dr. Fadia Afsana.
Thank you.
Now we move on to our next expert for this session, Professor Najmul Islam. Professor Najmul Islam is a teacher and mentor for many of the endocrinologists in Pakistan. I myself being one of his students. Professor Islam is the professor of medicine and consultant endocrinologist at Aga Khan University Hospital. He is extensive experience in undergraduate and postgraduate teaching, and he is currently the Dean and Convener of Endocrinology, College of Physicians and Surgeons of Pakistan. He is the founding member and past president of Pakistan Endocrine Society and is recipient of Lifetime Achievement Award from Pakistan Endocrine Society. He has extensive published in numerous national and international peer review index journals and has been a speaker for more than 230 invited lectures and presentations in national and international conferences. Thank you, Professor Najmul Islam, for your presence in today's session. Our next expert is Dr. Sadia Salman. Dr. Sadia Salman is currently the General Secretary of Pakistan Endocrine Society. She is the head of endocrinology at Department of AIMS, Jinnah Health University, and she has extensive experience in teaching in undergraduate and postgraduate students, examiner of endocrinology at College of Physicians and Surgeons of Pakistan, multiple publications in numerous national and international journals, and extensive speaker experience as well. Thank you, Dr. Sadia Salman, for your kind presence in today's session. So after the introductions, I will move on to our panel discussion, and I will first like to ask Professor P.K. Jabbar on the fact that diabetes technology, we know that continuous glucose monitoring devices are quite common in use world over, especially even in Southeast Asia, South Asian region, they are having a placement in managing patients with diabetes. So what do you see the use of continuous glucose monitoring devices for people with diabetes who are aiming to fast?
Thank you, Dr. Aisha. It's a very fantastic starting point now. But unfortunately, say CGMS or whatever glucose monitoring method, technology-based, say my experience is limited in Ramadan time. I should admit that. But I can tell you one thing, all these good targets are useful in our clinical practice. See, what is the use of the CGMS or continuous glucose monitoring system? It's to detect hypos and hypers. But mind you, what is happening here, whatever said and done, even though you are telling that it's a after maturing, after puberty, Ramadan fasting is essential. It is not really, of course, Islamically, fatwa is that's fine. In Kerala state or India and even United Arab Emirates, I was working there for a long time. See, everyone will observe Ramadan fasting. See, even type 1 patients, they will observe Ramadan fasting. So if we have type 1 patient, is it really need to observe Ramadan fasting? It's a controversial issue, but as far as I know, 2023 recommendation fatwa released by mullahs, it seems if the patient is getting totally uncontrolled and having multiple doses of insulin, better to abstain or don't go for Ramadan fasting. I think that there are religious fatwa also available for our Muslim community. But if we are observing Ramadan fasting, in my place, what we are doing, we'll go for the SMBG, self-monitoring of blood sugar. Probably we'll go for 5 times or at least 4 times we'll go, and SOS also will do it. And with that, we can pick up hyperglycemic episodes. Very clearly, you can take a decision also. There are various recommendations. The recommendation by IDF 21 and subsequently all the recommendations saying that if the blood sugar comes down less than 70 and blood sugar more than 300 milligrams per deciliter, you can break Ramadan fasting. But in my practice and in my observation, especially from Arab countries, see, this is not needed. If you have technological system, CGMS or flash, whatever system you have, this will be very useful to see the trend of the glycemic profile. So definitely CGMS or continuous glucose monitoring systems useful in our Ramadan fasting, even though I don't have much experience. But coming to the other high-tech gadgets with us, see, we have few patients, of course, not Muslim patients. We have the high-tech pump system is available. I have a feeling that it's my own opinion. The recommendation power is F. So if the patient can afford that, this will be a good gadgets for Ramadan fasting, especially for type 1, because you have a system, artificial pancreatic system is available. So the stopping of insulin infusion will occur so that you can act and you can take actions also. So, and see, you have artificial intelligence system is also coming up in a big way to tackle fasting or hypers picking up and appropriate management. So to conclude, all these newer technologies are really useful. It seems very promising, even the CGMS or Libre system or the latest pump system or artificial intelligence. All these things are useful. There is no doubt about that. Even the practical difficulties are there. Still, I have a feeling that we should follow SMBG or self-monitoring. Whatever times, it's okay, because if you go for capillary method, there is no problem for our fasting. Fasting won't break, so you can use it. It's very convenient. I would recommend, I have a feeling that that should be the procedure of choice for our Ramadan fasting. Especially, I can tell you one thing, in Kerala and India, we can't afford all this high-tech technology system. Over to Dr. Aisha for continuing the discussion.
Thank you, Dr. Jabbar. Yes, you are right that many of the people in this region cannot afford CGMs, but still, if used, they have a placement in managing diabetes during Ramadan fasting. We'll move on to the next question, and I'll request Professor Sanjay Kalra to kindly address that. During COVID time, we experienced the benefit of telemedicine and telehealth. And I'm sure each one of us was using telemedicine services. So what roles you see that telemedicine can play in supporting patients during Ramadan fasting?
Thank you, madam. Telemedicine has a very important role to play before and during and also after Ramadan. So studies from the Middle East have shown that when you have pre-Ramadan virtual connects with the patient, that increases the adherence during Ramadan, increases the adherence to CGMS and glucose monitoring as well. That's an important thing because you're able to counsel them, you're able to teach them that they have to monitor themselves. During Ramadan, telemedicine is important. Many people cannot travel. Sometimes there is no family member available, and there are so many other things to do. And then if Ramadan falls during our hot summer months, travel becomes even more challenging. During the monsoon, even more challenging. What are the things that we can offer during Ramadan to our patients, and what are some of the things that we have done at our center? The main focus, of course, is on adjustment of doses, glucose monitoring. We have CGMS, which is expensive, like Dr. Jabbar said, but then we also have cloud-based regimens. For example, you can use a Roche meter and you can use the My Sugar app to give real-time glucose values to your doctor. So that helps you adjust the doses. But apart from that, we can help our patient with the diet, with friendly recipes. And here I'd like to speak about the fact that not only should our recipes be healthy and tasty, they should also be cook friendly. So spare a thought for the person who is cooking the iftar food or who is cooking the suhoor food. So these are small things that we can share. In our center, we have worked on WhatsApp groups. And what I found in our center, and I'm sure Dr. Hamid will be able to add more because he has more experience, there were less of questions about dose adjustment because the children, the adults, they are all used to that. There were more questions about, can I eat dates or not? What are the gluco-friendly ways of consuming dates? How can I enjoy the taste of a date while, expanding it for 5 or 10 minutes? So these are things that we've talked about. My state is Haryana in northern India, a small state. We do not have telemedicine for Ramadan in our state, but last year, thanks to one of our political leaders, we were able to create a telemedicine consultation for all Hajj pilgrims. So all pilgrims going from our state, they were able to get the benefits of telemedicine before and during the Hajj pilgrimage as well. So that was something very nice that I think can be replicated across the region.
Thank you, Dr. Sanjay, for sharing your experiences of using telemedicine, not only telemedicine through an effective communication and easy communication with the patients during Ramadan and also during Hajj. Now we'll move on to our next question, which I believe most of our participants are really interested to know about. We discussed the oral anti-diabetic agents and their dose adjustments in last session, and today we'll be discussing about adjustments in injectable anti-diabetic medicine for patients who plan Ramadan fasting. So I'll request Dr. Faria Afsana to please share your views on adjustments of the GLP-1 analogs. If somebody is on GLP-1 analogs, at what time they should be taking their dose, and is there any dose adjustments required?
Thank you, Dr. Aisha, for the question, and also thank you for inviting me in this panel discussion. And now it is 3 weeks left for the Ramadan, and each and every patients are coming with the dose adjustment and the risk stratification. So one of the drug nowadays is used by many patients is GLP-1 analog. And for individually the GLP-1 analog, there is no dose adjustment actually required, but because it individually does not causes hypoglycemia. But the thing should be noted that we should start this GLP-1 analog at least earlier before Ramadan, not during the period of Ramadan, because it may sometimes present with some GI symptoms, and these GI symptoms may be very much severe while at the initial phase. So the patients who are getting GLP-1 analog from the long time can safely use this GLP-1 analog without any dose adjustment during the Ramadan period. But for the patients, it should be, for the physicians also, it should be recommended that do not start for the first time during the Ramadan period. And regarding the dosing, when to give, it can be given at the previous time and previous dose as it is prescribed earlier before the Ramadan period. So it can be used safely during without any event.
Thank you very much, Dr. Faria. We'll move on to next injectable anti-diabetic agents. What about intermediate acting insulin and basal insulin? So Professor Hamid Ashraf, please advise us on how to adjust intermediate acting and basal insulins during Ramadan.
So if we talk about the basal insulins, whether it's intermediate NPH, Detrimer, or long-acting like glargine or degludec, in that situation, it's better to use, if we can change the basal insulin to a long-acting or ultra-long-acting, they are definitely better than the intermediate acting. So if that change can be made during at least well prior to Ramadan, then it's a good thing. Otherwise, if the patient is taking intermediate acting insulin, in that situation, if the patient is taking daily dose once daily and the patient's glycemic control is good, HbA1c is around 7%, in that situation, we should reduce the dose by 10 to 20%, and it should be given at the time of iftar or at the time usual bedtime, because most of the hypoglycemia which happens during Ramadan, it happens during the last 6 hours of fasting. And if we are using, if the HbA1c is, for example, more than 7.5%, then there is no dose adjustment is required. Along with that, we need to tell our patient that you need to have glucose monitoring during at least first few days of Ramadan. They should do it quite frequently. And if the blood glucose remains between, you say, 90 to 160 or 90 to 180, then we don't need to make any changes. But if the blood glucose goes beyond these limits, then in that situation, we need to increase the dose. If the blood glucose is going, for example, more than 180, during the fasting period, we might need to increase the dose of basal insulin by 10 to 20%. Similarly, if the blood glucose is going down less than 90, in that situation, we might need to reduce the dose of the basal insulin by 10 to 20%. That's how we should use basal insulin during Ramadan.
Thank you, Dr. Hamid. And you have correctly mentioned that individualization of care would be important, because if the patient is very well controlled, then your dose adjustments would differ from somebody who is already entering Ramadan in a moderately controlled state. And then dose adjustments, which we'll be discussing in subsequent questions as well. Thank you very much. So we'll move on to our next expert panelist, Dr. Mariam Niaz. Dr. Mariam, can you guide us how to adjust the premixed insulin doses? We know that premixed insulin doses are very much in use in this region of the world, although not very physiological, but they are used. So how to adjust this insulin during Ramadan?
Thank you, Dr. Aisha, and thank you for this opportunity to join this webinar. So regarding the premixed insulin dose in Ramadan, actually, as you said, there are a lot of patients who are on this. Can you hear me?
Yeah, yes, we can hear you.
Yeah, so usually the different regimens are used for the premixed insulin. Some patients might be on just one single dose of a premixed insulin, and if the patient is only on one single dose, actually there's no need to change the dose, but this dose need to be taken just at iftar, that is when they break the fast. But if patient is taking twice daily dosing, then what we need to do is the higher dose, which is usually pre-Ramadan given in the morning, should be changed to evening pre-iftar when they break the dose. That would be the higher dose. And then the evening dose, which is the smaller dose, pre-Ramadan smaller dose, which needs to be changed to suhoor dose, that is the pre-dawn meal, just prior to the pre-dawn meal. And that dose also need to be adjusted around 20 to 50%. But we usually in clinical practice, although we say in guidelines 20 to 50%, in clinical practice, what we explain to the patient is, like, as you already mentioned, individualize the treatment. So it depends on what the patient is taking at the suhoor and everything. And then sometimes the patients are on 3 times daily dosing, also premixed, or sometimes they might be using premixed twice daily with a fast-acting Novorapid at lunchtime. So if it is the pre-Ramadan regimen, then we usually omit the lunch one, and then we just adjust the iftar and suhoor dose. And then this also should be dose titrated according to the self-monitoring blood glucose. Yeah, thank you, Dr. Asha.
Thank you, Dr. Mariam. Now we'll move on to multiple daily insulins, basal bolus insulin for type 2 diabetes mellitus, how to adjust doses of basal bolus insulin in type 2 diabetes. Dr. Wali Nasiri from Afghanistan is here with us. Dr. Wali Nasiri, can you give your expert opinion on this?
Thank you very much, Dr. Aisha, for giving me the opportunity to represent my country, and particularly Afghanistan and Friends Society in this prestigious meeting and conference. Before going to answering your question, you recited ayah number 183 of Surah Baqarah in the beginning of this session, and you told us about the obligation of this pillar of Islam. In the next ayah number 184 of Surah Baqarah, Allah subhanahu wa ta'ala say, فَمَنْ كَانَ مِنْكُمْ مَرِيدًا أَوْ عَلَى سَفَرٍ فَعِدَّةٌ مِّنْ أَيَّامٍ أُخَرٍ. Who is sick, everyone of you who is sick or he is on a journey, he is exempt from keeping the fasting. In the next ayah number 185, Allah subhanahu wa ta'ala say, يريد الله بكم اليسر ولا يريد بكم العسر ولتكملوا العدة ولتكبروا الله على ما هداكم ولعلكم تشكرون. Allah subhanahu wa ta'ala say that the desire of Allah subhanahu wa ta'ala is not to bring his servant or to put his servant in hardship. Rather, Allah subhanahu wa ta'ala always want for us to be in ease. That's why if the patient, especially I'm describing, I'm representing my society in my country in this, and I'm speaking from my people side. That's why in our society, mostly patients who are taking insulin, they are living in a situation where it's difficult to keep fasting. That's why we exempt them from fasting. Regarding answering your question, patients who are taking MDI protocol or multiple doses of insulin, the dose of basal insulin should be reduced by 15 to 30%. If the patient is taking it once in a daily, it's better to take it at iftar. But if the patient is taking basal insulin twice daily, it's recommended that the dose of suhoor should be reduced. Patients regarding short-acting insulin or rapid-acting insulin, the dose of rapid insulin, pre-lunch dose should be skipped, and the morning dose should be taken at iftar. Evening dose, which is usually taken at suhoor, should be reduced by 25 to 50%. But it depends upon the pre-iftar and pre-suhoor reading or post-iftar and post-suhoor reading. If the pre-iftar reading of blood glucose, if pre-iftar reading is less than 70 milligram per deciliter or 70 milligram %, then the dose of regular insulin or analog insulin should be reduced by 40%. If it's less than 90 milligram %, then it should be reduced by 2 units. If it's between 90 and 120 milligram per deciliter, the same dose should be taken as previous days. If blood glucose is more than 126 mg per deciliter, then the dose of regular or rapid-acting insulin should be increased by 2 units. If it's more than 200 milligram per deciliter, the dose should be increased by 4 unit. And if it's more than 300, then it is the patient should be encouraged to break his fast. Thank you very much. Over to you, Dr. Aisha.
Thank you, Dr. Wali Nasiri, for a very elaborate answer to the question, and especially taking us again to what Allah subhanahu wa ta'ala has given exemptions as well, which we have actually discussed quite in length in our previous session as well. Thank you very much. We'll move on to the next question, and I request Dr. Sadia Salman to please answer this question, that people are on co-formulations like GLP-1 and basal insulin, long-acting basal insulin co-formulations. So what kind of dose adjustment should be used for Ramadan fasting?
Thank you, Dr. Aisha. As already discussed about the GLP-1 analogs, they do not cause hypoglycemia. They are pretty safe because they reduce the sugar in a glucose-dependent manner. But basal insulin causes hypoglycemia. Any new medication should not be started in the Ramadan. The patient should meet the doctor before Ramadan, and the dose, obviously, if the patient is already taking, the dose is already well adjusted. But in co-formulation, because basal insulin is on the board, so patient can go into hypoglycemia. The dose steps which the patient is already taking, we will reduce it by 15 to 30%, and the time should be in the afternoon, not in the morning. And we will check the levels on the next day, and after checking the levels, we can adjust the dose accordingly. But because of the basal insulin, we have to reduce the dose. Thank you.
Thank you, Dr. Sadia. Dr. Mariam Niaz, can you elaborate more on dose adjustments of insulin during Ramadan? Dr. Wali Nasiri has briefly discussed that, but if you can tell us, our audience, a little more about those adjustments during Ramadan based upon the self-monitoring of blood glucose in those patients.
Okay, so during Ramadan, actually, the self-monitoring of blood glucose, SMBG as we call it, is very important because a lot of physiological changes are there, a lot of changes are there which will change the patient's blood glucose level. So actually, as we already have heard that if it is less than 70 milligram per DL, we should break the fast. And if it is more than 300, also 300 milligram per DL. But to adjust the insulin dose during the time of iftar and during suhoor time, we should actually advise and educate the patient 1 month prior to Ramadan. That is what we should do because we should make the patient self-reliant and teach them the symptoms of, make sure that re-educate them on the symptoms of hypoglycemia and how to adjust the dose and everything. As already mentioned, when we give the dose, we check the SMBG level at pre-iftar time as well as pre-suhoor time to adjust our insulin dose. So if it is less than 70 milligram per DL, we should reduce our insulin by 4 units. If it is less than 90, reduce by 2 units. And if it is between 90 to 126 milligram per DL, actually no change is required. And more than 126, increase by 2 units. And if it is more than 200, increase by 4 units. These are guideline adjusted, as I mentioned before, so it should be individualized. So these adjustments can be done every 3 days so that the patient knows her or his own dose. Like for iftar, the first day, the dose might be different, and when they check their SMBG and know that it is low, they know how to adjust their dose on the consecutive days. Actually, in our practice, what we do is, prior to Ramadan also, most of them, especially elderly people, type 2 diabetes who are already on insulin, they fast on Mondays and Thursdays prior to Ramadan also. So they are educated when they already educated how to adjust the dose. But of course, Ramadan is a different setting and then it might be different also. So we need to educate the patients how to use the self-monitoring blood glucose to adjust their doses. Thank you, Dr. Aisha.
Thank you. Patient education is very important if they want to have a safe fasting experience. And a well-controlled patient who has been under control throughout the year, they easily spend their Ramadan fasting as well. Thank you very much, Dr. Mariam. We'll move on to the next question. Professor P.K. Jabbar, can you tell us how safe it is for people with type 1 diabetes to fast during Ramadan?
So, that's a very beautiful question. See, if you go through the reference given by British Islamic Medical Association published in 2023, if the students are listening to me, you can go to the website and you'll get the beautiful reference, Diabetes and Primary Care, Volume 25, Number 1, 2023. See, you can categorize a patient as our friends. Of course, they are speaking as a mutawa. It's very clearly said, Islamic advice. There are 3 categories of patient. Category 1, there, what is written in a must not, mamnu hai. Okay, there is no need of observing Ramadan if the blood sugar is totally uncontrolled. If you have one episode of diabetic ketoacidosis also in the preceding 3 months, Islamic fatwa is there is no need of observing Ramadan fasting. The category B, type 1 diabetes mellitus, good control. I would like to discuss the topic in subheadings number 1, number 2, number 3. So you have a classical type 1 patient taking multiple doses of insulin, say 3 injections of regular, 1 dose of long-acting insulin. Such a patient, of course, you can't go for lunch dose of or noon dose of regular insulin. So probably that will be difficult for them. But I have seen cases or kids observing Ramadan fasting by quitting the noon dose of regular insulin. All right, okay. And they're unlikely to go for major complication if the previous control is okay and they're getting educated as you are doing now. And if the SMBG part is okay, or CGMS part, if you are using, or if they are using the latest pump system also, or artificial intelligence also, it's okay. Whereas if you take the second group of patients, they're taking 2 doses of idagas, okay, classical Rhizodeg insulin. There are good reports which showed if you are using Rhizodeg, you just take 2 injections, one in the time of Maghrib and second just before Subh or Suhu time. Probably hypoglycemic episodes are less and hyperglycemic excursions are not very high. So you can observe Ramadan fasting without any problem. But very commonly, as Dr. Aisha was discussing, our part of or most of our patients, they're taking mixed insulin. Even now, I have a lot of patients in Kerala state and India, we have a lot of patients that are taking 2 doses of mixed insulin. You can have little adjustments and good hydration you can manage. But if I'm repeating one thing very clearly, if the patient is taking multiple dose, poorly controlled still, and previous or preceding 3 months, you have diabetic ketoacidosis, what you can do if you want to go for this thing, you can go for Ramadan fasting under the supervision of diabetic educator and your physician. And whatever said and done, these people will observe Ramadan fasting. They can go for that, provided you know the complexities and problems and you are fully supported by diabetic educator and your physician. So by and large, probably it's not safe in certain group, and most of the patient you can start or you can observe the Ramadan fasting. Over to Dr. Aisha.
Thank you, Dr. Jabbar. We'll move on to the next question. If a type 1 diabetes patient plans to fast and he's or she is on multiple daily insulin, basal bolus insulin regime, Professor Najam, will you guide us how to adjust insulin doses in multiple daily insulin regime treated patients type 1?
Thank you, Dr. Aisha, for inviting me. Also, good evening and salam alaikum to all the participants of the webinar. So going to your question about the adjustment of insulin in patients with type 2 diabetes who are on basal bolus regimen. So, I mean, those who are already, the basal insulin has to be reduced by about 20 to 30%, and the time of taking the insulin should be either the same at night or they can be moved to iftar. So that's about the basal insulin adjustment. Coming on to the prandial insulin, obviously basal bolus patients usually take 3 insulins, but because there is no lunch, so there will be no noontime insulin. They will be taking 2 bolus insulin, 1 before Sahar and 1 before iftar. And obviously those who are following, those who understand the insulin carb ratios, they can continue the same dose of insulin and they can adjust their insulin depending upon the carbohydrate content of the meal that they're taking at Sahar and iftar. But those who are on a fixed doses and they don't understand the carbohydrate counting, they can continue the same dose at iftar for the evening dose that they are used to. but the seher dose has to be reduced by about 20 to 30% at for the morning insulin that they are taking before the breakfast. So that is sort of adjustment. But these adjustments are just a guidance that I have discussed. It has to be individualized depending upon the patient's previous control, because those who are well controlled, these things will apply to them. But those who are uncontrolled, these reductions may not apply to the same extent in each and every patients of type 1 diabetes. So that's briefly the adjustment. Thank you. Over to you, Dr. Aisha.
Thank you, Professor Rajam. So again, this highlights the importance of individualization of care, and a physician is actually the best person who knows how to individualize care for a particular patient. So we'll move on to the next question, and I'll request Professor Sanjay Kalra to guide us. If somebody with type 1 diabetes is on insulin pump or continuous subcutaneous insulin infusion, and they are planning to fast, how the doses should be adjusted, how the settings should be adjusted for Ramadan period.
Thank you, Dr. Aisha. And it would be apt to reassure all our colleagues and all our patients here that doing CGMS or applying a pump will not break the Ramzan fast. It is safe and it is approved by religious leaders. Now, multiple studies have been done on this. Like Dr. Jabbar said, mentioned in the beginning, we have few patients on pump, but that doesn't mean we don't have any patients. So first of all, the basal dose. Basal dose adjustment is anywhere between 0% and 25% reduction. So various studies have shown different results, but there will be a lot of inter-individual variability. So one way that we follow here is that during the current month of Shaban, 15, 16, 17 day, we do a kind of a test, kind of a fast, and we see what happens. There is no forcing the patient. The patient is also relaxed. So the patient begins fasting after taking a very early morning breakfast. We reduce the basal dose by maybe 10 to 20% and then just see what happens. In case the patient feels that she has to break the fast, there's no issue. But it helps us plan for Ramadan dose adjustment. Second thing is regarding the bolus doses at suhoor and iftar. So it is 2 doses that we require. So usually square wave will suit the suhoor meal and a dual wave will suit the iftar meal. Why we want dual wave is because there is a high carbohydrate and a high fat content also during that meal. So dual wave is better. Now, depending upon the time of the year, depending upon the cultural factors, not religious but cultural, some people may have 2 dinners. So you have an iftar and then 3 hours after that, again, you have a full meal. So then again, you will have to give a correction dose at that time. But a few things we would like to mention to everyone. First of all, it is approved by religious scriptures and by religious leaders. Secondly, pump is very safe. It will help many people be able to keep the fast. And when you also look at the dose adjustment, it is just 0 to 25%. It's not that you're reducing by 50 or 60%. So a simple tweaking here and there can help your patient fast properly.
Thank you, Professor Sanjay. You're right that with the latest pumps, the settings would actually allow a safer fasting experience. Thank you very much. So we move on to another very important question. And Dr. Faria Afsana, I would like you to address this, since I was doing my combined maternal medicine clinic yesterday, maternal diabetes clinic, and there were at least 4 or 5 pregnant women at different stages of their pregnancy. One was already having a growth restricted fetus on growth scan. The other was on basal bolus insulin. One was on metformin, and all of them were asking about Ramadan fasting. So I said, let Dr. Faria answer this question, and then we'll move on to get advice you accordingly. So Dr. Faria, what about pregnant women?
Thank you for the question. And if you consider the religious recommendation, there is actually religious
We are losing madam between. But you know, Dr. Aisha, while we wait for madam to come, this is actually one of the toughest challenges that we face in practice. You can read religion to say that it is an absolute exemption. So if you believe in the Holy Quran, you must exempt. But then there is a social pressure. Apart from that, there is an inner feeling, an inner desire. So the concepts are religiosity and spirituality. Each lady is different. And obstetric risk stratification is something that no one can do alone. You need the ulema, you need the lady who is carrying pregnancy, the obstetrician and the endocrinologist, the physician, everyone to work together. So again, while we wait for madam to rejoin us, a few things. Anyone who has fetal distress or maternal distress, even the slightest of symptoms, the slightest of signs, or the slightest of surrogate lab abnormalities, like maybe even trace ketonuria, please do not fast. Anyone who has a word of caution from the obstetrician, maybe the baby has, the fetus has IUGR or there is hydramnios, uh, the fundal height is not growing properly, then again it would be a good idea not to fast. And if with the help of senior ladies in the family and the religious ulema, we explain to the lady, she will listen. On the other hand, most pregnancies are, they are uneventful. Even gestational diabetes, if you are able to manage with medical nutrition therapy, that also should be uneventful if you manage properly. So in such cases, then you just weigh the religiosity with the risk of fetal or maternal distress. And then you counsel the patient, okay, let us continue if you are willing. But every week we have to check the fundal height. You can't do ultrasound every
Sorry.
week. Yeah, madam is back now. Yes.
So sorry for the poor network. And regarding the pregnancy and Ramadan fasting, actually there is for religious background, there is a religious exemption for pregnancy, lactation, and menstruation, like this type also the elderly and frailty. But we did study regarding the Ramadan fasting in pregnant women, and there are some physiological changes actually due to long time of fasting. Hypoglycemia may be there, and ketoacidosis due to long fasting is also possible. And of course, after the post-iftar glycemic excursion, that is very much hyperglycemic for a diabetic pregnancy also. And for this, hypoglycemia and diabetic ketoacidosis are the two risks for pregnancy with Ramadan fasting. And there are a few little number of studies which show some effects of both mother and fetus on this fasting level. And in one study conducted in Malaysia, they showed that in the first trimester, if the Ramadan is observed, fasting is observed during the first trimester, there is chance of fetal malformation due to hyperglycemia. And also in the second and third trimester, there may be a chance of macrosomia also. And so considering these peak and troughs of hyperglycemic excursion and hypoglycemia and chance of ketoacidosis, scientifically, actually, pregnancy should be exempted from the Ramadan fasting. And of course, close monitoring is very much important. If in spite of this patient wants to fast, in that case, close monitoring is very much crucial for successful pregnancy out.
Thank you very much, Dr. Faria and Professor Sanjay, for valuable guidance. Thank you very much. So we'll move on to the next question. What about senior citizens? If an elderly patient with diabetes is planning to fast, how to make his or her experience a safe experience? Professor Hamid Ashraf.
Definitely, this is also a very important question, as Dr. Sanjay Kalla sir has already talked that many times, even if the patient, they are exempted from the religious point of view, but because of their sheer intensity to participate in this fasting and feasting. So elderly is also one of the subgroup where they are at increased risk because there may be some functionality issue. They may have frailty. They might not be so much independent in their working, and their cognitive decline might be there. And in current scenario, there are many people elderly they don't have anyone to take care of them. So in absence of caregivers, fasting during Ramadan can be a big problem for these patients. So we particularly need a very good kind of risk assessment, which might have been discussed in the last, I think, discussion. So risk assessment is very important. And in that risk assessment, the things which we need to have a look on that is hypoglycemic unawareness, because that is very common in elderly. They might not have the adrenergic symptoms of hypoglycemia, say they directly have the symptoms, this neuroglycopenic symptoms. In that situation, things can go out of hand quite rapidly because they don't have the classical symptoms of hypoglycemia by which they can identify themselves that they are having hypoglycemia and take care of the remedial measures. Along with that, cognitive function and frailty is also, it has got highest marks in that risk assessment chart. So we need to look at that. Apart from that, because of multiple comorbid conditions during in these patients, for example, hypertension, CVD, CAD, and stroke, heart failure, polypharmacy, all these things are very common in elderly. So during the non-fasting hours of 8 to 10 hours, taking so many medications might be problematic. So we need to have a look at that also. Another problem which we face in management of diabetes in elderly is that we don't have a very good amount of solid data in this subgroup. Whatever data is that, it is very small in amount. We don't have dedicated data in this subgroup of patient, and whatever the recommendations are there, they are based on the expert opinion rather than any kind of, you can say, good data. And because of polypharmacy, there might be interactions between different medications. For example, patient is taking diuretics and patient is taking SGLT2 inhibitors. So in that situation, chances of fall, chances of hypovolemia, postural hypertension, they might be increased. So we need to take care of that also. Along with that, it has been seen that they are very particular about fasting. Around 70% patients, they fasted in elderly 65 years of age. 70% of them, they had fasted for the whole month of 30 days. So they are very much particular. So we need to have a very good education, very good amount of risk assessment. And we should be very particular about telling when to break their fast, because if they are not breaking their fast the moment it is required, then definitely it can lead to the problem, just not for the patient, but for the whole family. We need to have a good amount of discussion with the patient that if your blood glucose goes beyond 300 or it is going less than 70, in that situation, you should break your fast. Because if you are not doing so, then it might lead to problem, just not for yourself, but in the holy month of Ramadan, if you are getting admitted, because admission for hypoglycemia as well as hyperglycemia in elderly is much more common when compared to the non-elderly. So because they are they are in a very fine, delicate, balanced state. So even the slightest amount of any kind of insult can throw them out of this balance, and they need admission. So we need a very good education. If you talk about the medication, the guidelines broadly remain same in this subgroup. But the thing is that because of polypharmacy, we need to have a very good, we need to give a very good thought how to take this medication, at what time they should take. And during non-fasting hours, we should tell our elderly patient that you should remain adequately hydrated, because dehydration and risk of postural hypertension is very high in this subgroup of patient. And we should also tell them, because there might be some problems, so you need more frequent blood glucose monitoring when compared to a healthy adult person. So I think that's all. Thank you.
Thank you, Dr. Hamid. So we'll move on to another important comorbid and complication in people with diabetes, diabetic kidney disease. Dr. Mariam ne asked, can you guide us how can fasting during Ramadan affect individuals with diabetes who have a comorbid diabetic kidney disease as well?
Yes, yes. As we all know, when we do the risk stratification, having comorbids and complications like diabetic kidney disease puts the patient on a higher risk for complications during Ramadan fasting. In normal physiology, also in prolonged fasting can lead to dehydration and decrease in blood pressure and thrombosis. And in a patient with kidney disease, this could cause further kidney damage. When we risk stratify patients with CKD stage 3 and above actually puts them in high risk. Actually, CKD stage 4 and stage 5, they are at very high risk of getting complications during fasting in Ramadan. So religiously also, when we think of, when we know the advice which we have been given, they are actually exempted. But as we have already further discussed, sometimes it's individual, the patient might need to fast. So we should always advise these high risk patients, CKD stage 3 and above, to not to fast, especially if it is CKD stage 4 and 5. But if they want to fast, we should guide them with frequent SMBG monitoring and education. We don't have much studies assessing the impact on people with diabetic kidney disease, though there are limited studies, and these studies are also on very small number of patients, and they have found actually inconsistent results. Some studies actually has found that there's a temporary improvement in eGFR and a reduction in proteinuria in people with CKD, while other studies have actually shown deterioration in renal function. When we look into guidelines, actually we should advise these patients to be very cautious in CKD stage 3, 4, and 5. Then when we talk about CKD, we have to talk about patients who are on dialysis. Some studies have actually shown that the patients who are stable and on dialysis, they can fast safely. The most important word here it is that these patients should fast safely, and this could only be done by close monitoring and frequent consultation. So this should be done prior to Ramadan, and during Ramadan also we should have very close contact with the patient. As I already mentioned, not much studies are there, but one of the landmark study, DARK Global Survey, found that hypoglycemia and hyperglycemia was very frequent, with more ER visits and hospital admissions in patients with diabetic kidney disease. So actually we need more prospective studies, especially in different stages of the kidney disease.
Thank you, Dr. Mariam, for highlighting all the challenges that can occur in a person who is planning to fast and is having diabetic kidney disease. Now we'll move on to what kind of dietary and medication adjustment should be done in these patients who have diabetic kidney disease. And I'll request Dr. Muhammad Wali Nasiri to please take up this question.
Thank you very much, Dr. Aisha. However, it's difficult to treat and manage patients who are suffering from diabetic kidney disease. But and as Dr. Mariam mentioned, that patients who are suffering from stage 3 diabetic kidney disease, they are exempt from fasting, and they should be encouraged to break their fast and not to keep fast. However, patients who insist and intend to fast despite having stage 3B or stage 4 or end stage renal disease, then in that time, several points should be encouraged. And several points should be focused on. Number one, time of medication. The time of medication should be adjusted according to estimated GFR in the stage of the kidney. And number two is hydration. Special focus should be done on hydration. Patients who are suffering from diabetic kidney disease, they should be encouraged to stay adequately hydrated, considering any fluid restriction based on kidney functions. Number three, type of carbohydrates. Type of carbohydrates, patient should be encouraged to choose complex carbohydrate with a low glycemic index in order to minimize postprandial glycemic excursion. Number four is protein intake. Regarding protein intake, diabetic kidney disease patients are classified into two groups. Number one is group who are non-dialysis dependent. Number one is group who are not dialysis dependent, and number two are dialysis dependent patients. In dialysis independent diabetic kidney disease patients, it is encouraged that the protein intake should be less than 0.8 gram per kg body weight per 24 hours. But patients who are undergoing dialysis or renal replacement therapy, they are encouraged to take protein more than those who are non-dialysis dependent. They are encouraged to take protein from 1.2 to 1.3 gram per kg body weight per 24 hours, as those who are going to dialysis or undergoing renal replacement therapy, they are in a catabolic state. Electrolyte imbalance in sodium intake is another issue which should be focused on, and they are encouraged to restrict their sodium intake to from 1.5 to 2.3 gram per 24 hours. Another issue is regular monitoring of blood glucose. They always if they insist to stay fasted, their blood glucose should be frequently tested, and self-monitoring of blood glucose is advised to them. Each approach should be individualized, and patient dietary modification, lifestyle modification, and medication modification should be based on the stage of the kidney disease and on eGFR. And the last point, distribution of nutrients should be nutrients should be evenly distributed through the non-fasting hour during Ramadan in diabetic kidney disease patients. Thank you. Over to you, Dr. Aisha.
Thank you, Dr. Nasiri. You have given a very good guidance to all our attendees. We have learned a lot as well. Thank you very much. We'll move on to the next complication. What about atherosclerotic cardiovascular disease? And I request Professor Najmul Islam to guide us. If somebody with diabetes has an underlying atherosclerotic cardiovascular disease, how safe it is for them to fast, and what kind of dose adjustments will they require?
Thank you, Dr. Aisha, for this question. I mean, the literature is not very clear on this, but the experts feel that these patients who have atherosclerotic cardiovascular disease are at an increased risk of complications because of fasting during the month of Ramadan. That's a general view, but the studies are limited. As I was just looking at, there was a systemic review that was published in 2020 in diabetes research and clinical practice, in which only 22 studies were there, and they concluded that the evidence is not there to either support or against fasting in patients with cardiovascular disease in terms of increased risk. So that is the literature, but generally they are at increased risk, and we should be advising them, and risk stratification is essential before the start of Ramadan. And those who are at low risk or low to moderate risk can be allowed to fast. And these includes the patients with a stable angina, stable hypertension, stable heart failure sort of patients, and those who had permanent pacemakers, they can fast. But those who are at a high risk and those at a very high risk should be told not to fast. So that's the way we risk stratify them. The risk that is associated with fasting in these patients are they can go into hypoglycemia, they may have dehydration, and they may be missing their medications for their underlying disease, and that may predispose them to the worsening of that condition. So, so it's important that risk stratification be done before, and we should advise them accordingly. And those who are in the safer category can be allowed to fast with an advice, but those who are not in the safer category should be told not to fast. But if they still insist, we have to guide them and we have to support them, because they are taking their own decisions, but we as physicians should be guiding them so that they can safely sail through the month of Ramadan with fasting. So that is the general view that I have told you about the risk factors associated with atherosclerotic cardiovascular disease have been studied. There are certain risk factors that are improved. There are certain risk factors that are not improved, in fact worsens. For example, there are studies to show that there is some weight loss. There are studies to show that there is some weight gain. So those sort of things are there. So no uniformity is there in terms of risk factors. So those are about the risk factors. But again, I think in the end is that we need more research in this field so that we have more scientific evidence to back our advices to our patients. Thank you.
Thank you, sir. Thank you very much. Dr. Sadia Salman, so if a person with stable atherosclerotic cardiovascular disease plans to fast, how would their management be optimized?
Thank you, Dr. Aisha. Professor Najam just discussed about the atherosclerotic cardiovascular disease risk factors. In our DAR risk calculator, the stable macrovascular disease is a point of 2, but unstable macrovascular disease is a point of 6.5. So the unstable macrovascular disease is already in a very high risk category. But the stable macrovascular disease, if the patient wants to fast, then he should meet before the Ramadan, well before the Ramadan, 6 weeks before, to the cardiologist and endocrinologist. So he can have about the current situation, current cardiac status, and the current sugar readings. So that can be adjusted. There should be a trial fast for the patient because there are multiple medication, the blood pressure medication, diuretics, diabetes medicine. So trial fast is always better for these patients. And there should be, as Dr. Nazim said, the hydration status should be clearly mentioned to the patient. Dehydration can lead to thrombosis as further worsening of these things. So hydration and the adequate sleep. Sleep deprivation can generate arrhythmias. So these things should be mentioned to the patient during the Ramadan. And there should be a 6-day rule. If the patient is not well, he should not fast. And when to terminate the fast, he should know if he is not well and during the fasting condition, he develops symptoms, then he should break the fast. And the medication, as we talk about the SGLT2 inhibitors, that the better time is at the iftar time. There is no clear literature about the medication, but the patient, if it is better if the patient is using diuretic and the antihypertensive medication, if it is on both time, the higher dose should be at the iftar time, and the diuretics, it is better to be taken at the iftar. So the things can be, it is usually during Ramadan, the patient awakening time is after iftar, and after suhoor, they mostly go for sleep. But so these medication and the blood pressure is usually on the lower side in the pre-iftar time. So if the higher dose of antihypertensive medication, we can shift it to the iftar time. But again, this is individualization. We have to check the blood sugar readings, avoid hypoglycemias and hyperglycemias. Hypos can lead to arrhythmias, and the blood pressure medication, we have to check the blood pressure during the fasting so we can adjust it on the next day. Over to you, Dr. Aisha.
Thank you, Dr. Sadia. You have very important points that you have advised us. Thank you very much. What about, we'll move on to the next question. Dr. Fadia Afsana is here with us. What are the implications for individuals with diabetes and who have a comorbid of cerebrovascular disease during Ramadan?
Thank you for the question. The question answer is almost same to as Dr. Sadia was telling about the macrovascular status, the present status of the patient, the hemodynamic status. That is very much important to consider while advising fasting for this particular cerebrovascular disease or stroke patients. And in that case, a patient with very old stroke, hemodynamic is stable, and there is no complication, then he can fast with supervised advices and adjustment of the doses of antidiabetic as well as the antihypertensive medications. But the patients having recent stroke or very recent history of any such event should be exempted from the fasting. And while considering the fasting, those who will fast, of course, cardiac and the cerebrovascular status should be very much important, because during fasting there is a chance of dehydration and increased chance of thrombosis and further stroke exacerbation. In that case, considering this, the patient should be individualized and should be individually assessed for their risks for Ramadan fasting. So in that case, if we can ensure the proper risk assessment, then the patient can fast easily, even with a mild or very old stroke. But in acute strokes, they should be exempted.
Thank you, Dr. Faria. Thank you very much. Very practical advice. We'll move on to the next question. So Ramadan is over now. Everyone has celebrated Eid, and we know that Eid is actually a feasting season. And following Eid, Professor Jabbar, when will you advise your patients to come to the clinic for follow-up, and how now their doses should be adjusted post-Ramadan? And how can they take that experience in future for better diabetes control as well?
It's a good question. I think in say Ramadan, it's not for say spiritual benefit alone. There are n number of metabolic benefits. Physical benefits are there. It's very clear. Your triglyceride level will come down if you follow Ramadan properly. It's very important. What is happening in our community and country? So we are observing Ramadan fasting. Probably they are not observing dietary modification of diabetes during Ramadan. In certain part of world, they're taking lot of high calorie diet. All those things are happening. That is not good for our health. After finishing Ramadan, and you see, and there is a beautiful topic in stress and diabetes mellitus. I still recapitulate what was happening with our high-tech politicians. All these politicians having lot of mental stress. Is very difficult to control their diabetes mellitus. So once you go for Ramadan fasting, your spiritual benefits are there, mind calmness will be there, metabolic benefit will be there, and your heart is in a good shape. In fact, say lipid profile will become better, triglyceride will become better, STL minimal elevation will be there. So all these benefits you have achieved during Ramadan fasting, properly observing Ramadan fasting. Now, what is your aim is to maintain this one. After 1 month, you know what is going to happen. See, if you go back to the normal diet, you can go for your modification of medication as per your physician's advice. After 4 weeks or after 6 weeks, you can meet your physicians and you can go for the original medication which you used to go for your treatment of diabetes mellitus. What I want to tell you that the most important aspect is to maintain the benefit of Ramadan fasting is very important. For that, you should observe good dietary modification and exercise. Of course, religiously, you should take medication as per the advice of physician. In this moment, let me tell you one thing, say, if you go for Ramadan fasting and post-Ramadan management is also very good and very efficient in terms of lipid profile and glycemic control. And BP also will come down little bit. There is no doubt about that. So there are many benefits which you should maintain after Ramadan also till next Ramadan fast. For that, you should observe all the rules and advice of your physicians also. Thank you very much. Over to Dr. Aisha Sheikh.
Thank you, Professor Jabbar. Professor Sanjay Kalra, taking your experience with extensive research that you do, and we have been discussing quite a lot of subject of Ramadan, where we know that there's still scarcity of data. What areas, because there would be many researchers in our attendees as well, what areas do you feel that there should be more research and exploration for diabetes and Ramadan?
A lot has been done, madam, over the past 2 decades, but still much more needs to be done. And here I would like to involve Professor Hamid Ashraf in the discussion because he runs one of our most prestigious endocrine departments in India. Some things that we can do. We tend to speak of Ramadan risk stratification in biomedical terms. But when we are speaking of diabetes, we always say that it is a biopsychosocial condition. We also use the word person-centered care so often without even bothering about the definition. But actually, if there is one phase of life or one phase of the year which teaches you person-centered care, that is pre-Ramzan and Ramzan. If you can learn how to manage diabetes during Ramzan, then you have learned person-centered care. This is very humble submission. So first focus for research should be religiosity. We have actually got objective scales for religiosity and for spirituality. The Urdu words are mazhabiyat and ruhaniyat. You can measure mazhabiyat and ruhaniyat with scales. These scales may have been created in the West, but they have been customized to the Islamic religion as well. So we should be able to involve these in all our discussion, in all our research, irrespective of what research is going on and where it is being done in Ramzan. That is the first submission that I would have. Second is we now have newer drugs available. Like even when we say the word premixed insulin, we have co-formulations. When we talk about prandial insulin, we have ultra rapid acting insulins like ultra rapid acting Lispro, fast acting Aspart. We should focus on these as well to see whether we can make fasting safer and more meaningful for all our patients. Two more aspects I would like Dr. Hamid to speak about these, please. One is Ramadan nursing, something that they have begun working upon in Aligarh now. And the second is emergency planning, how they do audits or how they plan audits within their department. And Dr. Hamid, if you could take over, please. And then we will add one more topic at the end, that is hypoglycemia risk stratification.
Yes, sir, definitely. We are planning a few studies. One of them is that to do some audit, what kind of emergency admissions we have during the month of Ramzan, and to see what is the difference if something related to Ramzan is coming during emergency, for example, the myocardial infarction or any kind of problems or adverse drug reactions, which is very common in elderly, and they are presenting to our department. So we are planning to make a task force of our postgraduate residents who will audit the admissions during the holy month of Ramzan. And if we can find something by which we can improve the care of our patient, which will be useful in the next year, definitely we can do so. This is a thing which is we are thinking to do this year.
Another aspect is hypoglycemia risk stratification. Just like all diabetes is not the same, all hypo is also not the same. So if you have empathic nursing available, two things. First of all, there is something called the HAQ. Hak in Urdu means right, or hukuk means rights. We have hypoglycemia awareness questionnaire. So we can share this with our patients before Ramadan so that they become aware of their symptoms of hypo. We teach them about what neuroglycopenia means to them, and that will help in a much safer fasting experience. Second thing is, now supposing somebody gets hypoglycemia at 10 a.m. in the morning, it is still 10 hours till dusk. Then our approach will be different. But if it is just minor hypoglycemia, the patient had taken glipizide in the morning or maybe a basal insulin in the morning, and it is already 6:15 p.m. We are expecting that dusk will fall at 6:30. Then if you have good nursing care, you are able to check the pulse BP regularly, you are able to make sure that cognitive function is normal, you might actually be able to help that patient fast for 15 minutes extra just by comforting her, by just being with her, telling her, Madam, I'm here with you. Now, this is difficult to do in a busy government setup, but if there is empathy, if there is compassion, even any worker, if it is a class 4 worker, a sweeper, you just have to have someone to say every 2 minutes, Madam, are you fine? So this is also risk stratification from a hypoglycemia perspective. It will depend upon whether the patient has renal failure or not, what is the blood urea, did the patient take a rapid acting insulin or a basal insulin, how many hours or minutes till dusk, how many doctors are available at that time in casualty. But I know that Dr. Ashraf is working on this as well. And we can call it Ramadan nursing, compassionate nursing, hypoglycemia, risk stratification. Whatever name we give it, that is a separate matter. But this is something where we need objective research.
Thank you very much. And I'm sure that maybe over time, the artificial intelligence can play its role in such kind of situations, because having nurses at that time of the day where maybe they will be busy with many other things, I think there is a scope for artificial intelligence and an AI bot that can guide the patient that, okay, you are safe. So maybe Dr. Sanjay, you should take this up as a research question.
No, like the audit they said in Aligarh, you just do an audit like in Shaban and Shawwal, how many road traffic accidents were there in Karachi or in Aligarh or in Trivandrum or in Male? During Ramzan, how many road traffic accidents were there? How many admissions to the metabolic or medicine ward? Hypoglycemia, how much came in the morning, how much came in the evening? Once you do that simple audit, all that is required that you post an extra resident or an extra nurse in the evening in the pre-iftar hours, 4 hours, if you find that the burden is more. So even if you can't post a nurse, maybe just a nursing student who can help out. So of course, every ecosystem will be different, every healthcare system will be different, but this is where research is required. And like Madam rightly said, artificial intelligence, all these things will help us do a better job for our patients.
Thank you very much. So we'll move on to the next very interesting part of our this session is about the endocrine conditions and Ramadan. fasting. We'll move on to thyroid disorders, and I request Professor Hamid Ashraf to take up hypothyroidism. So, hypothyroidism, when should be they taking their thyroid hormone replacements, and how will fasting impact the thyroid status in somebody who has hypothyroidism?
Yeah, definitely. As we know that levothyroxine is the most commonly used drug for treatment of hypothyroidism, whether it's primary hypothyroidism, secondary hypothyroidism, autoimmune hypothyroidism, post-surgical hypothyroidism, irrespective of the etiology of hypothyroidism. Levothyroxine remains the cornerstone of the treatment. The standard recommendation is that we should take it at least 45 to 60 minutes prior to the first meal in the morning, prior to breakfast. But that becomes difficult during Ramzan. Because no one can wait for. Actually, I was going through a study. I found a study where they have given levothyroxine at the beginning of the iftar, and after that they made to wait for 30 minutes. So I think how cruel it can be. So for making someone for at least half an hour just
That
to
is
take
painful.
levothyroxine.
That
So
is
a study
cruel,
was there.
that is cruel.
Yeah. So what I have observed, because after that we were doing some kind of audit in our OPD. So we found that most of the females in our society, they wake up very early during suhoor because they have to prepare the sehri, and after that had to offer the tahajjud prayers also. So most of the females which I have asked, they usually woke up quite early during sehri. So in that we are doing a study also basically. In that, we have told them that you should take your levothyroxine at least half an hour before the sehri. And those, specifically the males and the younger ones, the adolescent ones who are always lacking time in everything, in that situation, we have told them that you should take it at the bedtime before at least 2 to 3 hours after your the last meal. And the effect of Ramzan on fasting on the thyroid hormones, the studies have shown that there is slight increase in TSH levels. That was sometimes significant, but they did not go into the overt hypothyroid range. And there was very less amount of, you can say, change in the free T4 or total T4. But definitely those who have fasted, their TSH was high. So this is the thing which happens, and that usually does not lead to any kind of problem in most of the patients. But here a subgroup of patients, for example, those who are pregnant, where we need a quite strict control, specifically those who are having, you can say, bad obstructive history, there it can be a problem. So in that situation, we might tell the patient that at least you should take this very regularly, and you should try to maintain the gap of at least 30 to 45 minutes between the levothyroxine and at whatever Sarian or is how I think we should proceed with this problem.
Thank you very much. And I'll just share one of our studies which we did on hypothyroidism in Ramadan. And Professor Sanjay, we actually measured the quality of life as well, because you were mentioning religiosity and spirituality index. And quality of life of all patients pre-Ramadan compared to post-Ramadan was much better. And that was because of the spiritual experience that they have during Ramadan. And Dr. Hamid is right that for women, it's not a big problem because they're waking up early, making sehri and everything. For men, it becomes a little bit different. But in our study, we did not find a major change in TSH level pre and post Ramadan. It was just 2.38 TSH difference. So thank you very much, Professor Hamid. Really nice thoughts. Dr. Mariam Niaz, what about somebody who is having hyperthyroidism and is on antithyroid medications? Any recommendations for them?
Yeah, for those patients who are having thyrotoxicosis, newly diagnosed patients, and who are uncontrolled thyrotoxicosis, actually they are advised not to fast if they're having uncontrolled thyrotoxicosis, because the dehydration, this can worsen their symptoms, tachycardia and diarrhea as well. But for those who are having mild symptoms and who are controlled on medication, then of course they should continue their fast. And regarding the medications, actually not much of an issue if they are on carbimazole or methimazole, because this can be given in a single dose or BD dose. But for those patients who are on high dose of PTU, they might have some limitations because these are given much frequently, like 3 times a day, like that. So if needed, if they can change to carbimazole prior to the Ramadan, but otherwise can be given even 12 hourly also. So it's only for thyrotoxic patients who are uncontrolled, which is an issue for these patients. But not much data is there out there. I think we need more studies on thyrotoxic patients and fasting. Yeah.
Thank you, Dr. Mariam. Professor Najmul Islam, what about adrenal insufficiency? I think that becomes the most challenging group for healthcare practitioners and endocrinologists.
Thank you, Aisha, for this question. Obviously, as it applies to other ailments, all patients who with adrenal insufficiency planning to fast should have a risk stratification prior to the start of Ramadan. So if they are stable, they can fast during the month of Ramadan. And then the next question is, how do the medications be adjusted? Most patients are on hydrocortisone, and hydrocortisone is given in divided doses, 20 to 30 milligrams, and sometimes, in fact, 15 to 20 milligrams in divided doses. Some are on thrice a day in the morning, noontime, and then about 4 to 5 p.m. So that becomes an issue for those who are on hydrocortisone. But those who are already on prednisolone once a day, life is easier for them. But anyway, those who are on hydrocortisone can be shifted to prednisolone for the month of Ramadan. They have to take it at the time of Seher or Sahur. And that should be sufficient really for them and without any issues. But if the Ramadan is during a period where the fasting period is short, they might as well get away with hydrocortisone. For example, sometimes it can go up to as short as 8 to 9 hours in certain countries where with cold weathers, really, sometimes the Ramadan is very short. In that case, hydrocortisone can be done. But this part of the world where we are from, usually they cannot manage with hydrocortisone alone, because the first dose that they would be taking at Seher, the second dose will be at Iftar, will be too long a period, and they would be at a high risk of having hypoadrenalism during the day. So it is advisable that they should be shifted to prednisolone. The doses that are recommended are usually 3 to 5 milligrams. Unfortunately, we don't have other strengths of prednisolone available, at least in Pakistan. So we only use 5 milligrams, but sometimes a lower dose like 3 milligrams can be used as well. And they should be ready that in case of intercurrent illnesses, they should not be fasting, and they should be following the sick day rules. They should also be having a kit for intramuscular hydrocortisone in case they go into a crisis. The bracelets should be there so that as it applies other times as well, so that their safety is not compromised. So yes, they can fast and with adjustment of their medications. And this adjustment or changeover should be started before the start of Ramadan rather than from the first day of Ramadan. So over to you, Dr. Aisha.
Thank you, Professor Najam. Very valuable guidance. We'll move on to Dr. Faria Afsana, who will guide us about hypoparathyroidism. Somebody who is already on multiple daily calcium and activated vitamin D preparations 3 times or 4 times. How can they fast?
Thank you for the question. And the stable with the blood calcium with the calcium replace is very much important. Sometimes the patient is stable with calcium doses and it sometimes them daily dose into 2 parts in Iftar and Sahur. But if the patient is not stable and the hypocalcemia is fluctuating and he or she required multiple daily dosing with huge dose calculation, in that case, it is not possible for him to continue Ramadan fasting. And it is advisable for them if they may go for a trial fasting during this mid-Shaban period. And in that case, 1 to 2 fasting days can give an assessment about how they can cope up with the fasting. And in that, we can help them to advise about this hypocalcemia in hypoparathyroidism patient. Thank you.
Thank you very much, Dr. Faria. We'll move on to panhypopituitarism. How can a person with panhypopituitarism have a safe fasting experience? Dr. Muhammad Wali Nasiri.
Thank you very much, Dr. Aisha. Actually, it's a little bit difficult question to answer because there is a few research and data on this answering this question. There are very few research and data. Actually, the patient should be treated the same as the pre-Ramadan period, and the patient should take regularly the hormones which he was taking before Ramadan. Only the timing of taking hormone and receiving hormone should be changed. As Professor Najmul Islam mentioned that how hydrocortisone or glucocorticoid should be taken. Growth hormone replacement does not change much because it's taken once daily, as well as estrogen per woman who are less than 50, androgen per man. It doesn't change much. Regarding replacement of thyroxine, it's a little bit difficult in Ramadan too, because we have only few hours non-fasting period. That's why it should be taken in a time where there should be meals. This is the recommendation which I found in the literature that patient should take in mind when they are keep fasting during the holy month of Ramadan. As a last and take-home message, I just want one thing that should be mentioned, that we have two things in Islam regarding Islamic knowledge. One is Farzul Ain, and another is Farzul Kifaya. Everyone, every Muslim who wants to keep fasting during the holy month of Ramadan, whether he is a patient or a healthy person, he should get and he should acquire the basic knowledge regarding fasting, not in-depth knowledge. The basic knowledge is, as Ramadan is obligatory, the basic knowledge regarding fasting is also obligatory. Another is Farzul Kifaya. Farzul Kifaya is in-depth knowledge, and only if one imam from a village have in-depth knowledge, it's enough for the whole town and for the whole village. Another thing which should be kept, and doctors should be updated regarding the Sharia law. In Ramadan, we have two things. One is rukhsat and another is azima. If a patient is exempt from keep fasting during the holy month of Ramadan, and you mentioned that as well, but if he wants to not to fast, he is rukhsat, he can do it, and it's a chance from Allah subhanahu wa ta'ala. He can use this chance. That's why every doctor and every patient to keep Ramadan safely, they should have at least basic knowledge regarding fasting, rule and regulation of Islam regarding how to fast. Thank you very much. Over to you, Dr. Aisha.
Thank you very much. Thank you. Very practical advice, Dr. Wali Nasiri. We'll now move on to the question and answers. There are a few questions that I will request our panelists to address because other things are already being covered in session 1 and session 2. Professor P.K. Jabbar, one question is about the use of SGLT2 inhibitors during Ramadan. Is there any safety signal, and should ketone testing be done in somebody who is using SGLT2 inhibitors?
It's a beautiful question, I would say. So before 2021 recommendations, we were a little skeptical to use this SGLT2 molecule for diabetic patients. So now IDF is giving a very strong comments and suggestions to use SGL2. So SGL2 seems to be safe, but only thing is what I feel, the timing you can change. Okay, instead of sahur time, after Maghrib, after breaking Ramadan fasting, you can start taking this molecule. There is no issue. There is no recommendation like that as far as I know, but I think that will be a good idea or advice to go for SGL2 at the time, at Maghrib time. Okay. And as far as I know, there is no recommendation to go for ketone body monitoring those who are taking SGL2. I think it's a pretty safe molecule. Now you can start, but see, anybody is from like in a humid situation, lot of sweating situations, and will try to hydrate before subh time. That's also a good message you should keep in mind. Okay, over to Dr. Aisha.
Thank you, Professor Jabbar. Professor Najmul Islam, there's one question about somebody who is adolescent, recently diagnosed with diabetes. Will you guide them or advise them or allow them to fast during Ramadan?
Thank you, Aisha. Recently diagnosed, mean how recently? If it is only a few weeks and the diabetes is not very well controlled, then I would not advise them to fast during the coming month of Ramadan. But if it is few months and they are well controlled, and depending upon which type of diabetes they have, adolescent may be having type 1 diabetes, may be having type 2 diabetes. So type 1 diabetes is slightly different from type 2 diabetes. So those things will matter really when deciding whether they will be allowed to fast. And the same thing applies, which we have discussed so far for the adolescents as well, regarding fasting and the adjustment that is required. But if somebody has been diagnosed very recently and the Ramadan is only 1 or 2 weeks ahead, then that it's not advisable for them to fast, because the adjustment of medications and the blood sugars has not been done as properly up till that time. So that's what I say. I wanted to just add one more thing, that in my question that you asked about adrenal insufficiency, I forgot to mention about fludrocortisone, the melanocorticoid replacement. The melanocorticoid replacement carries on as usual at Sahar time. So they can take it in the morning at Sahar, and that is enough, and there's no major adjustment required in that.
Thank you, sir. Thank you very much. There is Dr. Hamid Ashraf, I would like you to address this question, because when we look at the guidelines, International Diabetes Federation and Diabetes Ramadan guideline, for breaking the fast 300, if hyperglycemia, there are 2 extracts over there, which is actually meant to individualize your decision. You cannot give a blanket advice to everyone to break their fast if they are going beyond 300 milligram per DL of blood glucose. So what is your opinion on this?
That's actually a very good question. As Dr. Sanjay sir has already, we were talking that individualization is particularly very important during Ramzan. For example, if a patient has got blood sugar of 310, and patient does not have any kind of symptoms, patient is not having any kind of extreme thirst or extreme weakness, and time left for iftar is you can say half an hour, 1 hour, then definitely in that situation, I don't think it would be judicious to break that fast at that time. But if, for example, another patient who is having just blood sugar of 250, patient is having extreme thirst, patient is having extreme weakness, and there might be, if ketones are available and the patient is doing that, and the patient is an elderly, so in that situation, and there are, for example, 2 to 3 hours left there to break the fast. In that situation, definitely one can break fast even if the blood sugar is not at 300 level. So at higher side, we can decide depending upon the patient's overall clinical condition. But if the patient is having hypoglycemia, in that situation, definitely we should be more cautious, because many times the sign and symptoms of hypoglycemia, that is the adrenergic sign and symptoms, may not be there, specifically if the patient has hypoglycemia in preceding weeks or months. In that situation, we should be very careful. And if someone wants to continue it, then there should be, I think, more frequent checking of blood glucose and more frequent checking of, you can say, vitals that can be provided. Otherwise, in hypoglycemia, we should tell the patient it's always better that you should break the fast, because if you are doing according to the guidelines, what we are telling, then probably you might be able to keep more fast in coming days. But once you are admitted, then the problem will be your many of the Ramadan fast has to be skipped because of this reason. So individualization is the key, but we should be definitely very cautious, specifically if we are dealing patients who are elderly, who are having you can say complications like macrovascular complications or diabetic kidney disease. In that situation, definitely we should be more cautious.
Thank you, Dr. Hamid. Very elaborate reply to this question. Dr. Faria Afsana, one of our attendees, Dr. Nadia Shams, has actually asked about how to interpret ketones in urine or serum in somebody who is fasting, because we know that there will be kind of a starvation ketosis as well. So how to interpret ketones during fasting?
Actually, while the patient is fasting, especially probably in the pregnancy, there is a chance of fasting ketonuria also. So in the prolonged fasting, there is a chance of ketonuria. We must look at the blood sugar, of course, and how is the blood glucose level. That is very much important. And if possible, the serum ketone level that may be assessed, and the patient is dehydrated or not, that is the important thing. And if there is dehydration and the patient's blood sugar is high, then he should break the fast and then take appropriate measures for management of this hyperglycemia.
Thank you. Thank you very much. Professor Sanjay Kalra, I would like you to address this question. What about fasting outside Ramadan for better diabetes control? So they're asking about intermittent fasting concept for diabetes control.
There is a lot of discussion regarding this. And when your patients ask you, I think the best answer is to be person-centric. If your person is obese, is not on sulfonylurea, not on insulin, and thinks that intermittent fasting will help him or her improve self-discipline, then it's fine. But however, if your patient is on a long-acting sulfonylurea, on multiple insulin doses, is not overweight or obese, then it would not make sense. Another thing is religion. If your patient is used to intermittent fasting, for example, we have the Jain religion in India, where intermittent fasting is a part of life. Then to tell someone who is maybe 65, 70 years old to stop fasting, and she has been doing it for the past 50 years, that would be, it would not be welcome. So it has to be really person-centric. In a nutshell, anybody who has a long duration of diabetes, multiple complications, especially autonomic neuropathy or renal failure, and is on multiple drugs, we should actually actively dissuade intermittent fasting. Someone who is obese, wants to lose weight, and feels that intermittent fasting will help in self-discipline, there are not too many of drugs going on, we can encourage. If you look at evidence, intermittent fasting, the people who swear by it, they actually like it a lot. But when you look at the evidence, it doesn't make too much of a difference to final outcomes in terms of weight or in terms of glucose control. It is finally the calorie restriction and carbohydrate restriction total throughout the day which will make an impact.
Thank you very much. So with this, we come to the end of our session. I'm really grateful to all our panel of experts to participate in these two sessions, for your valuable remarks and comments and experience that you have, years of experience in managing these conditions. And I'm sure our attendees have benefited. I'm really grateful to all the attendees for their participation in both sessions. Just a couple of announcements. Both sessions are recorded, and these will be available on Pakistan Endocrine Society's YouTube channel and Facebook page as well. And maybe our panel of experts will advise us whether they can share these recordings on their own society's pages as well. Similarly, we have got all your email addresses, and we'll be emailing you the certificate of participation. And hopefully, with all this guidance that you have acquired during these two sessions, you will be feeling more confident and better able to advise your patients for a safe fasting experience. and stay blessed and have a wonderful Ramadan this year around. I'm really grateful to all of you, our honorable, esteemed panel of experts, and looking forward to more sessions in future as well. See you all. Most of you will be in ICE meeting, and inshallah we'll meet there. Thank you very much. Allah Hafiz.
For
Assalamu alaikum.
closing, say, may I
Thank
take
you.
opportunity
Thank you.
to
Allah
thank
Hafiz.
the organizers on behalf of me and my team, Dr. Sanjay Hamid and Endocrine Society of India. Special thanks to organizers for arranging a beautiful meeting, especially pre-Ramadan time. Thank you very much. Once again, inshallah, we'll meet you after some time. Assalamu alaikum wa rahmatullah.
Walaikum assalam. And thank you very much. I will like to extend my gratitude and thanks to Mr. Harun Michael, who is our national coordinator, and Mr. Anas, who has provided IT support and has guided us to conduct this webinar. Thank you very much. Allah Hafiz. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much. Thank you very much. Allah Hafiz.
Thank you very much.
Thank you.